What is that?
90 degrees.
Generally 45 to 90.
45.
So basically, if you're sitting on the end of the exam table and they're sitting upright, they're already in the semi-high phallus position, okay? If they were in a bed laying flat and you came in to do an assessment, they'd have to sit up, right? Okay. Expose the chest area while providing privacy, so we'll make sure you guys wear like a tank top or something like that, because it's tough to assess through the scrubs, it's just as difficult. You're gonna do, inspect anterior and posterior chest for symmetry, shape, movement, alignment of trachea, and thoracic configuration. So you'll look anterior and posterior, the chest should be symmetrical, right? No asymmetry noted. So if you say the chest is symmetrical, then I know that there's no asymmetry. But generally, chest is symmetrical bilaterally, no asymmetry noted. So the movement and the alignment of the trachea, where should the trachea be aligned? Midline. So you just verbalize trachea, visualized midline. And thoracic configuration. What are we talking about the thoracic configuration? Shouldn't be barrel chested, right? No flail chest. It's usually a 2-to-1 ratio, right? 2 this way to 1 this way. Should be a 2-to-1 ratio. Is there? I'm sorry.
You said barrel chest or what?
Flail chest, no
What's
flail.
that?
So flail chest, so barrel chest means they got that big round barrel chest,
Yeah.
which is abnormal. So a flail chest would mean that it flails out on one side,
Okay.
usually due to a series of cracked ribs. A lot of times from a trauma, you get flail chest,
Yeah.
what they call a flail chest.
So
they,
barrel chest is more like symmetrical.
it's rounded, it's really rounded. You would notice it's it's abnormal.
Okay.
So generally people's chest, you kind of have a little bit of that V-shape.
But that's from like a condition,
Yeah, usually
and then
it's
flail
usually
chest
the-
would be like an injury.
Usually flail chest is from injury, and usually it's related to fractured ribs. Observe ventilatory pattern and presence of masses. So what should the ventilatory pattern be? Should be regular, non-labored, right? And no presence of masses noted, right? So you just look at it, you don't notice any masses. Palpates anterior and posterior chest with fingertips for fremitus, tenderness, crepitus, and retraction. So what is fremitus? It's a vibration. The crackling, that's crepitus,
Okay.
right? That's that kind of I don't like to call
Rice
it
Krispies.
the Rice Krispies or the little bubble wrap underneath the skin, right? Retraction, what is retraction?
Is that like when they use accessory?
Yeah, usually, a lot of times you'll see it up here, you'll see this pulling in right here, a lot of times you see it right up here.
So you wanna see no retraction?
You don't wanna see retraction, that means that they're struggling. Palpates for respiratory excursion and tactile fremitus. What is respiratory excursion? Yeah, that's when we put our hands on the back, right? Remember, at the back, and we kind of see it go like that. Should be normal. And tactile fremitus, meaning we feel it, right? Any fremitus, any vibrations. Percussed for tone, start at the apices of the scapula. So we're gonna go, kind of atop the scapula across. 1, 2, 3. 1, 2, 3. What should we be hearing?
Resonance.
Yeah, it should be resonance, right? Then we're gonna percuss tone. Oh, we did that. Auscultate anterior, posterior, and lateral breath sounds over intercostal spaces. Auscultate voice sounds. So bronchophony. What is the bronchophony? 99, right? And what should we hear?
Muffled.
Should be muffled, right? Not clear. What is egophony?
E.
E,
You're not
right.
supposed to hear A.
We shouldn't hear A, we should hear E, right? A muffled E. And whispered perquilically? What is that?
Whisper what?
1, 2, 3, right? That's when they turn their head, you say whisper 1, 2, 3, and you're listening with your stethoscope, what should you hear?
It should be like.
It should be very muffled, you really shouldn't hear anything.
Yeah.
Wait,
Okay.
they're turning their head?
Yeah, they're gonna turn their head and you're gonna say whisper 1, 2, 3, and you're gonna listen, right? You should
Okay.
really hear, really shouldn't hear anything. Maybe you might hear it very faintly, but you really shouldn't hear anything. Those are identify breath sounds by type, quality, and pitch. Identify normal or adventitious. So what kind of breath sounds do we have here? So we have bronchofascicular, vesicular, and what?
Bronchial.
So what are these? Bronchial, right? Bronchofascicular, vesicular, right? Kind and vesicular across the chest, front and back. So what should we hear? They should are a little different when you listen to these, right? It should be clear. Yeah, right. You shouldn't hear any wheezing, any of that high-pitched stridor. Remember we listened to the stridor? You shouldn't hear any of that. But that's where you might hear like a wheezing or something like that. If you heard that, that's where you would describe where you heard that. Or you could hear absence of breath sounds, right? So when we listen to the lower lungs, and if they had pneumonia, we might hear an absence of, if they had a left lower lobe pneumonia, so in a left lower lobe, we might hear an absence of breath sounds, right?
Mm-hmm.
Okay. And assess the respiratory rate accurately, so you gotta count the rate again for a minute. But we've been doing that all semester. You guys should be pretty good at that by this point. Right? You've been doing it on your patients all semester in clinical. All right? Questions on that? That's the respiratory assessment. Pretty straightforward. If you forgot what the breath sounds or the egophony, you can go on and listen to the concept lab again in Shadow Health. It's there for you to review. The respiratory sounds are actually pretty good. I'm pretty happy with them on there. That's actually one of the better labs.